who is the affiliation and consultant HOD in Pain and Palliative Medicine, Rajgiri Hospital, Ernakulam. And he is also a visiting faculty in many hospitals, such as TIPS Trivandrum, MNJ Institute, Hyderabad. He's also a visiting faculty in Department of Philosophy, Kerala University, Trivandrum, and also in the hospital which I've mentioned. So basically, he's an eminent person in this field, and his personal special interests are communication, oncology, and respiratory palliative care. Generally, we are told to be successful, you have to be in the right time, right place, everything. So similarly, an important thing is that you have to convey it also in the right way. How, when, and what is what he is going to enlighten us so that we are all successful in our field. Welcome, and the floor is yours, Dr. Biju Raghavan.
Dr. Biju, sorry, you are muted.
Sorry about that. Thank you, Madam Radha Venkateshan, for your very kind introduction. And thank you, Sri Priya, for hosting this. And I think we are already due. So without much ado, we'll start today's session. We are going to do the first part of a two-part series on medical communication skills. The second part will be at another date, which Sri Priya will inform you. And today we are going to do part one, which is essentially the basics. With that, I will share my screen. I hope you can see. Sri Priya?
Yes, sir.
Can you confirm?
Perfect. Yes, sir. Perfect. We are good to go.
All right. So as I said, today we will be dealing with the basics of communication, medical communication skills. That incidentally is the hospital where I work in. It is in Alua, not Kalamasheri. It is in Alua in Ernakulam district. For those of you who are outside of Kerala, Ernakulam is bang in the center of the state of Kerala. So, so that is where I am right now. And this is an old study way back in 1986, and old is gold. This talks about patient satisfaction. So this came up in the headache journal. And what they found was the best predictor for resolution of a headache problem was the patient's perception that they had an opportunity to tell their story and discuss their concerns about the headache fully with their physician during the first visit. So patient's perception. In short, if your patient perceives that he or she has been listened to, then the clinical outcome is affected positively. There are a lot of medical errors which happens because of poor, inadequate, or miscommunication, and they are completely preventable. We all know about the look-alike, sound-alike drugs, and how there's a lot of perception in the society that we gave the wrong kind of injection, etc., etc. We keep hearing these kind of things whenever some unfortunate incident happens for a patient, and if comes in media, it always is portrayed along those lines. Often is portrayed along those lines. So medical errors, and they happen a lot actually. Doctor-patient communication is fairly complex phenomena. There are multiple dimensions to it. For example, when you get proper information, your ability to come to a proper diagnosis improves. Nowadays, it's the era of blanket investigation, and there are some people who would be happy if they have to shell out a lot of money in investigation. But by and large, we have to be very, very calculated in the kind of investigations we order. And for that, if we have a fair bit of information that we get from history taking is almost a dying art, but it is very, very relevant. So good history taking is possible with good communication skills. The more information you have, the more power you have to arrive at diagnostic accuracy. Now, it is not enough to come to a diagnostic accuracy, you have to treat the patient. But if the compliance is poor because the patient does not understand why you are prescribing whatever you are prescribing, then the person may or may not take it. And if the compliance is poor, then your clinical outcome is likely to be poor. Therefore, good communication skills will help you make the patient understand why you're prescribing whatever you're prescribing. And when the patient understands, they are more likely to comply. And when patients complies with your management strategy or your prescription, the outcomes will be better, are likely to be better. And when the clinical outcomes are good, the patient will be happy, satisfied. The patient's family will also be happy and satisfied. And if your patient and family is happy and satisfied, it improves the morale of your team, not to say your own morale. It gives you a sense of satisfaction that what you are doing, the work you are doing, is worthwhile, as compared to a situation where many patients and their families come and complain to you or your team that they are finding they're very frustrated, things are not working out, compared to more number of patients and families who come to thank you or express gratitude, or at least they are happy and satisfied. This also has an very important aspect on patient safety. I just mentioned earlier about why it is important to learn communication skills, because it improves the patient safety. And apart from their happiness and satisfaction, when you also take care of the safety, you are safe. You are safe on many, many ways. I've just written chances of litigation, you being taken to court, comes down. But in our country, we know many a times the medical professionals, doctors, nurses, and whoever is available are sometimes physically harmed by enraged patients and their family members. So good communication is good for the patient and their families. It is good for the organizations you're working for. It's good for society. But first and most important, please understand, it is good for us, those of us who are working in the healthcare industry, for our peace of mind, for our prosperity. So we learn communication skills for our own selfish interest. I underline that we should learn communication skills for our own selfish interest. It should serve us first and foremost. Of course, it helps the patient and family and society at large. So one of the most basic, the most fundamental aspect of good communication skill is our ability to listen actively. Hence, today's session is dedicated to active listening. Because as the quote says, communication is key to a successful relationship, not just personal relationship, but professional relationship. Our relationship with our patients and families, our relationship with our colleagues, our relationship with people who are in higher authority than us and those in below working under us and helping us out. So communication is key to successful relationship 360-degree. But in the core of a good communication skill is the ability to actively listen. So what are we covering today? As part of active listening, primarily we are going to split into two. One is positive body language, and second would be some verbal do's and don'ts which are going to be helpful. So as I said, today I'm dedicating the basic communication skill is dedicated to active listening and two components of it. So why should we learn body language to begin with? I mean, we have been doing fine. But the problem is that when we speak to people, we are often not aware of what is our body conveying, what is our face conveying, what are our hand gestures conveying, and are we aware that what we are saying verbally, is it matching through the body language? Sometimes it can be conflicting. And because surprisingly, most of us are really not aware of our own body's language. Therefore, many a times we can say the nicest of things from our point of view. We may be giving a lot of information from our point of view, but it does not appear to be so to the person sitting across us as and listening to us. Because what we say should match our body language. But also, more importantly, you must understand that the major component of any communication is body language, not just professional communication. Any communication is body language, anywhere from 70% to above. In some situations, sometimes 100% is body language. Therefore, since the major component of any communication is body language, therefore, that is also a good enough reason to learn body language. However, body language is a vast ocean. You can't probably finish up with everything that you can learn in a lifetime. And definitely, I will not attempt something foolish in today's session, which is of fairly limited time period. Therefore, for you, I have just chosen very few points, around 6-7 points that I want to concentrate on, which are going to be of practical help with our day-to-day interaction with our patients, families, colleagues, everybody. So first is eye contact. It is the spark which starts the engine, and it is also that sustains the engine running. And by engine, I mean interpersonal relationships. So the first and most important part of nonverbal communication is making eye contact. Now, what is the real life context? If you are a doctor and your patient walks into your OP and you are focusing on your what do you call patient case sheet, or you're focusing on the computer, not looking at the patient when the patient and the family when they walk in, that is poor eye contact. The first, leave everything. The first contact has to be eye contact. And then you can go and look into the case sheet or the computer, but first make the eye contact, because that is where the first impression happens. And when you make eye contact, you are establishing a human to human relationship. That does not mean staring into somebody's eyes. You just look at the patient's face. Now, just making eye contact is not good enough. You welcome them with a warm smile. And even if you're wearing a mask, your smile can be seen in your eyes. And your smile can be heard in your voice. Just like your laughter can be heard in your voice. Similarly, your smile can be seen in your eyes and can be heard in your voice. Therefore, wearing a mask is no excuse for not smiling. However, we human beings are psychologically tuned to smile at only those people we know and like, not to people whom we don't know. Definitely not at people we don't like. Most of the time, our patients and family members are people who do not come under our group of people we know intimately. They are not our family friends or close friends or close relatives. So the smile does not come naturally. Therefore, you have to practice what is called a professional smile. It is just like a regular smile. Only thing is you have to think about it. But it is worth the effort. And where can you practice it? You can practice in a safe place, which is your work environment. Start by smiling purposefully. Think about it and smile at the security guard you meet at the entrance of the hospital. Smile at the lift boy or the lift girl. Smile at the ward boy or the lady who cleans or the gentleman who is helping out in the ward activity. Smile at colleagues whom you don't know very well. And you have to think about it because it will not come naturally. But if you practice it enough, it will then become a spinal reflex. You don't have to think about it. It will come naturally. Anything resembling a human face passes in front of your face, a smile will break out on your face. You will not have to make any effort. Just like you learn to take blood pressure, initially it was very difficult, but and you had to think about hearing the lubbed up sound when it starts, when it stops, and all of that. It was very complicated. But now, if you are experienced, you can take a blood pressure without thinking about it. You can take it as a spinal reflex, right? Similarly, just like taking blood pressure is a skill, a professional smile is a skill. It will come only if you practice it. If you think I'm a nice person, I will smile. It will not come, I can assure you. Professional smile comes only with persistent practice. And if you make promise to work hard to if you promise to work hard on your professional smile, I will give you a bonus. Like if you go to a supermarket and you want to buy something and you are surprised that there is, if you buy one, you get one free. So if you promise to practice on your professional smile, I guarantee you, you will have a very nice tone of voice, free, free, free. You will not have to work hard on that. You don't have to, in fact, work on it. I challenge anybody to have a grumpy face and have a nice tone of voice. It is just not possible. You can have a nice tone of voice, a very warm, welcoming tone of voice, only if you have a smile on your face. You just cannot have a grumpy face and a nice tone of voice. Similarly, if you have a smile on your face, you cannot have a bad tone of voice. You cannot have a cold tone of voice. So good smile and good voice go together. Just practice good smiling. You will get a good tone of voice, totally free. You don't have to make an effort. Now, why is that important? Because a warm, welcoming tone is very, very satisfactory. Just like eye contact and a smile. And you might have heard, it is not what you say, but how you say that sometimes gets you into trouble. So if you want to stay out of trouble, develop a good tone of voice. And how can you develop it? By practicing professional smiling. Now, this is a very important slide. I want you to focus on the left hand upper picture, you see a healthcare professional standing by the bedside of a patient. And when you see they are making eye contact, but to make this eye contact, this patient has to turn his head. So you can see the sternocleidomastoid projecting out here. So it may be okay for a few seconds, but if you want to have a sustained conversation, this position will become uncomfortable for this patient, because to sustain eye contact, this person has to turn his head to look at the healthcare professional. Whereas if she were standing somewhere near the foot end of the person, this person could have made eye contact much more comfortably. So when you enter a patient's room, whether it is in the hospital or when you're making a home visit, if the patient is lying on a bed, first position yourself initially
Dr. Biju?
Maybe some internet issue with him, Sri
Or
Priya.
I think he got a call in between, like, maybe.
He'll
So we
come
will
back.
wait for him.
right. So I just talked about you positioning yourself near the foot end of the person. Were you able to follow till that point?
Yes, till that we could hear, sir.
Right. So that was the first point. When you start, position yourself near to the foot end. Now come to the top end right picture. You can see here is a healthcare professional sitting near the foot end of the patient. And see, the patient can comfortably make eye contact. Though the family member or has to turn the head to make eye contact with this person, but at least it is comfortable for the sick person. Now, when you sit by the bedside of the patient, you increase satisfaction, because here the eye contact on the left hand side is from top to bottom, and this creates hierarchy. So when you position your body at eye level with your patient, it creates equality. And creating equality in communication increases satisfaction. So it is comparatively equal. Whereas if somebody is sitting or lying down and you are standing, it is not equal. So creating equality in eye contact improves satisfaction. And improving satisfaction is the name of the game. That is what we are all aiming at. So position yourself. If the patient is standing and you are sitting, that also creates inequality. And if you can't offer a chair because you don't have a chair to offer, then you can also stand up. And that way, both people will have equality in eye contact. It is not an equal relationship, but at least you can create equality in your body language. When I say it is not an equal relationship, because anybody who is in the healthcare service, inside the healthcare environment, is above the patient and family who has come to seek healthcare. So they are seekers, we are providers. So it is not an equal relationship. But with our body language, we can create a sense of equality, which will improve satisfaction. So just by sitting down at the bedside of a person who is either lying down or sitting, you are creating that sense of equality, which will improve satisfaction. Coming to children, because we as adults are bigger in size compared to children, we have a tendency to bend down to look at them. This also creates inequality. Children are also disadvantaged because them being children, there is no chance of equality usually in their life. But if we create this sense of equality by bending down at our knees, or at least pulling up a chair and sitting down when we are talking to a child sitting in a chair or in a bed, here also we are creating that equality of eye contact. So this helps in creating a bond with the child, because we are not scary to the child anymore, because we have brought ourselves down to the same level. It is not enough to love children, it is also important to respect children. Body posture. Now, this was about body positioning, and what I want to convey is bring your body to the equivalent position of your patient and their family, if possible, at least to the patient. So this creation of equality improves satisfaction. The other important part is body posture. I'll just ask you, how many of you would want to speak to the person, gentleman on the left hand corner? How many of you want to talk to this person? Not many. How many of you would like to speak to this lady? Now, the difference is the positioning of their spine. We hate somebody who sits in a lordosis position, or for that matter, stands with a lordosis. But we like somebody who sits or stands with a little bit of kyphosis. Because when you adopt this position of kyphosis, you are conveying, without you knowing it, your body is conveying, I am here to listen to you. And that is the soul of active listening. So what your body is conveying, I am here to listen to you. Remember when you were sitting for your Viva exam in your, in your final exam, this is probably how you sat in front of your examiner, because you are conveying that I am here to listen to every question that you want to say. You would not sit like this in front of your examiner. So why do you want to sit like that in front of your patient or their family members? Right? So lean a little forward. A slight kyphosis of the spine improves satisfaction for your patient and family. So these are some examples of that. Another important area is respecting body space. We all have spaces around us. We have the intimate space where we allow only those with whom we are intimate, our close family members, our close friends, close relatives, other people, our colleagues whom we meet day to day. Only if they become intimate, we are happy that they come very close to us. Otherwise, we would have a bit more of distance. Intimate space is about a feet or two from our skin. The social space is about a meter beyond the intimate space, and beyond that is the public space. So people we know, we meet on a regular basis, we would attain a space of social comfort. Whom those we are very intimate with, we will attain a space of intimate comfort. Rest others, we maintain a distance of public comfort. However, in our profession, the patients are not somebody we meet regularly, or they are not in our social circle, definitely not part of our intimate circle. But because of a profession, we may have to intrude into their body space. We may have to touch them, palpate their abdomen, look into their mouth, and so on and so forth. So when somebody intrudes into our personal space and we are not intimate with them, it seems like a violation. It is uncomfortable. And it reduces satisfaction. But then, as part of our profession, we have to do it. They understand it. There is this concept of implied consent. They come to us and they know they will be touched. It is part of the whole process of seeking medical care. But still, at the psychological level, it is uncomfortable. So how do we reduce this discomfort? By telling them what we are going to do. For example, if I were to examine you with my stethoscope, I would put the stet in my ear and show you the chest piece and maybe shake my head, or maybe I'll say, I'm going to check you. That is enough. You don't have to take a formal written permission, because it is about preparing the mind of the person before we touch them. So just before you are about to commence your physical examination, tell them you are going to do that. And at each point, you tell them, I'm going to check your tummy, I'm going to check your spine, etc., etc. So that they are mentally prepared for what is coming. And that reduces the distress associated with being violated. There are two examples of this. You see this gentleman sitting in a chair, and here is a medical professional, and look at the facial expression and the body's reaction to this seemingly aggressive intrusion into this person's personal space. This is not the kind of kyphosis I am talking about. I was talking about a gentle kyphosis. This is an aggressive kyphosis. And look at the staring into the eyes. All of it. And look at the person's position with a stet around the neck. Definitely a person in the medical field, in the healthcare sector, a very, very powerful position. And this is a patient. You can see some tubes and all. This is a person who needs the service, and hence not much power. Dependent person on the system, on the services. It's scary. So look at how this person is going back, so as back as possible as the chair would allow. So this is going to create dissatisfaction. And look at another picture. This incidentally used to be my palliative nurse. This is a picture from the home care. And here you can see almost everything that we talked about. We talked about eye contact. We talked about smile. The tone of voice is not possible because it's a picture. And you look at the body position. Both are sitting. And hence the eye contact is equivalent. And look at the body posture, a slight kyphosis. You don't have to bend the whole spine. Just a tilt of the head towards the patient is good enough. And similarly here also, a slight kyphosis. Of course, you can't determine how the patient will react, but you can change your body language, right? And comfortable distance between these two. So this is kind of the perfect scenario that we should be aiming for. And last but not the least, the touch, a human touch. A human touch is the most powerful therapeutic tool that we as healthcare professionals can have. But we don't use it as much as we should. The safe places to touch, gender neutral places to touch, are the palm of our hand, as in a handshake, or the back of our hand, or the arm, or the forearm, or the arm, or the shoulder. But never grip somebody or pat somebody, because these are hierarchy. You cannot grip somebody higher in position than you. You cannot pat the back of your teacher, right? So what you can't do to somebody socially higher than you, you should not be doing to somebody lower than you. A gentle touch is good enough, but you should do it. In my day-to-day practice, when people come and see me in the OP, or when I go and see them in the IP, or when I go and see them in the home care, my usual practice is give a handshake at the end of the interaction, and their eyes light up. And it's very, very important that we do it, right? So finishing with the body language part, it is very, very inadequate, just 6-7 points. If you are interested, just Google for body language for medical professionals, etc. There is a lot of material out there. Please feel free to go and learn more. And the more you do it, the better you become. Because communication skills is not a talent, it's a skill. Anybody can learn it, anybody can practice it, anybody can become good at it, and anybody can subsequently teach it. So coming to some verbal do's and don'ts. Your pain is better now, isn't it? So when you ask a question like that, you, the high and mighty doctor or the nurse, sometimes a patient who comes from a, a socio-cultural background which makes the person timid may not be able to say it in your face, no, I'm not at all feeling good, your medicine did not help me. The person is more likely to shake the head, but the person may be scared to tell the truth. So instead of asking, your pain is better now, isn't it? You ask, how are you today? Just ask an open-ended question, and you will get all the information, not only about the pain, the thing that he could not sleep because there was a lot of noises in the other room or in the next bed. So you will get more information, and the more information you have, the more power you have. Knowledge is power, information is power. So if you ask a leading question, you may or may not get the right answer. If you get the wrong answer, then definitely it's going to be very, very problematic in your clinical outcome. Second, do not minimize my problem when I say I have a toothache. Oh, it is just a toothache. Why are you making a song and dance? Do not compare my problem. You go and see the children in the cancer ward. They have real pain. Your toothache is nothing. Because when you minimize my problem or you compare my problem, you are going to create a lot of dissatisfaction in me. Because for me, my problem is the biggest problem in the world, and you just minimized it. And for me, my problem is the only problem in the world, and you compared my problem with something else. You are going to create a very dissatisfied patient. Therefore, do not minimize my problem. Do not compare my problem with anything else, despite you having a very good intention of trying to help me out, but don't do it. Instead of that, just acknowledge my problem. Oh, it must be terrible for you, that to think. Great, I'm happy you acknowledged. And normalize my emotional experience of my suffering. This must be terrible for you. You know, anybody in your position would you would behave like that. I can understand. So you are not normalizing my problem. You are normalizing my emotional experience of the problem. You are not saying your toothache is normal. You are saying that because of this distressing toothache, you know how you are behaving. You know, it makes perfect sense to me. You must be suffering so much. And you have a happy and satisfied person, a patient, because I understand that you at least, you know, you are able to understand that I'm suffering so much. That is the whole point. Don't give false hopes. I have stage 4 CA lung, and you tell me, I don't know, but you tell me, don't worry, everything is all right. You take this medicine, come back after 2 weeks, you'll be just fine. What happens when I come back after 2 weeks? Much worse. Hey, you told me that I'll be fine. I'm much worse than that. Now I'll be angry at you. I definitely don't trust you anymore. I'm frustrated. So don't give false hopes. Don't just give hope. You just press a button and some nice words comes out of it. No, you listen to what my concerns are, what my fears are, and then give me realistic hope. An example of realistic hope that I do almost on a daily basis. Patients who come to me in my OP, the patients I go and see in IP, patients I go see home care, many of them have an incurable disease. Many of them have an incurable, progressive, advanced medical condition, and they are terminally ill. Some are chronically ill. They are never going to get up from their bed. Some are not going to live for long. So I tell them, when they ask me, that the disease is not curable, it is progressive. The doctors who could treat it, they have done the most. Now, that option is not there. However, I assure you that I'll make sure that you do not suffer. That I can. I cannot cure your disease, but I can make sure that you do not suffer and you can have my services as long as you need me. And when I tell them, I am not saying something unrealistic. With my training in palliative medicine and pain medicine, I can realistically give any person this assurance that they will not suffer. Physical comfort, peace of mind, and dignity of life is not very difficult to achieve. It is not very difficult to provide. It does not cost a lot of money. And when I tell them, the usual reaction I get is, doctor, that is all that I ever wanted to hear. And this happens to me over and over and over again, year after year after year. Now, please understand that sometimes we give false hopes because we are scared ourselves of how to talk about this. That is why it is very important to learn communication skills. Have a calmness and confidence in yourself that even if your disease can't be cured, your comfort can be ensured, your dignity of life can be ensured. And that makes a training in palliative care a very empowering experience. No matter what you get trained in, surgery, medicine, ENT, ophthalmology, gynec, cardiology, neurology, gastroenterology, anything, if you have learned the skills to provide comfort, irrespective of the disease status, then you never have to abandon any of your patients. And that is the realistic hope we give to our patients on a daily basis. How is your pain? Pain is reduced. Great. So I've just heard this and I've assumed that things are fine. If I ask, so do you have satisfactory pain relief? Not satisfactory. From severe, it has come down to medium. That is not good enough. So do not assume when people say something, ask more. I am so scared. Would you like to tell me why? I am so worried. What are you worried about? I am so angry. Can we talk about this? So when people, especially in high emotion, are verbalizing something, don't take it at face value. Try to find out why people are saying what people are saying. And this will prevent you from not assuming. Because when you assume, you may have a totally different idea than what the reality is. And that can be dangerous. I once had a patient. I was doing my post-graduation in pain and palliative medicine, and there was this patient who initially was seen in gastroenterology. They found that he had a chronic liver disease, and he was an alcoholic. And then they also found that he had hepatocellular carcinoma. And then they referred the patient to the oncology department. And the oncologist did a lot of investigation. This patient was admitted and was in the hospital for a couple of days. The oncological evaluation was done, and it was found that he had a metastatic hepatocellular carcinoma with a very advanced chronic liver disease, and neither the gastroenterologist nor the oncologist had anything to offer. So they referred to palliative care, and yours truly, as the PG, had gone to see the patient. And when I went to see the patient, it was, I think, a 3 or 4 cubicle bed. And when I went to see the patient was not in the room. I asked the nurse where the patient was. The nurse said, probably he's at the end of the corridor watching television. I'll go and call him. So the nurse went and called this gentleman. He came. I could see him walking down the corridor. And as he approached me, he had a broad smile on his face. And I said, hello. And then we walked into the cubicle and he sat on his bed, and I said, I'm Dr. Biju, I'm the pain doctor, I came to see you. And before I could complete, he just said, doctor, I know everything. The problem is in my liver and my condition is. So this was non-verbal. So he was saying, doctor, I know everything. The problem is in my liver and my condition is, means God. And it would have been very easy for me to assume that he knew that he had cancer and it was advanced. He knew that he had advanced stage liver disease. Nothing more could be done. That is the end of his story. But he was very stoic. He was taking it very well. He was very courageous because he had a smile on his face. He's prepared for everything. All of these things I could have assumed. However, thanks to the training of my teachers, I did not assume. I just asked him. He said, doctor, I know everything. The problem is in my liver and my condition is this. So I asked him, can you explain? What are you trying to convey? Then he said, doctor, in my good days, I used to drink a lot. And because of that, now there's a lot of pus in my liver. That was his understanding of the situation. He had no idea he had an advanced chronic liver disease. He had no idea he had a metastatic carcinoma, hepatocellular carcinoma. And what if I just asked him, assuming, so since how long have you known about your cancer and cirrhosis? It would have been such a shock to him. He might have jumped out of the window and committed suicide. So please understand, your words can really injure people psychologically and sometimes physically. So do not assume. It's a very, very dangerous thing. But assuming comes very easily to all of us. Therefore, it is important not to assume. Just we are all very familiar with history taking. So just history taking 2.0 from my side, incorporating all the communication skills that we talked about. Start with the smile, greeting. Greeting starts with eye contact, smile, and a nod of your head. And you can see what is culturally appropriate in your place. You can say hello, good morning, namaste, namaskaram, etc. Then the next thing is to get comfortable. You be comfortable. If you have gone to visit them or if they have come to visit you, make them comfortable. Offer them a chair, or if you have gone to visit them at home or in IP, pull up a chair or a stool or anything on which you can sit. You can not only you become comfortable physically, you are also creating satisfaction for the patient and family. Then start the interview with an open-ended question. Don't ask, how's your pain today? Just ask, how are you today? And then let them speak. Because listening without interrupting is a very, very important skill. There are studies which show that doctors interrupt the patients from the time the patient opened their mouth to the interruption is around 12 to 14 seconds. encourage, not only you should not interrupt them, you should encourage them to talk. And how do you encourage? You maintain eye contact. You don't stare them in the eye, but you maintain eye contact, nod your head from time to time, and make encouraging sounds or words like okay, go on. So this kind of encouragement helps the patient, especially the timid patients who may be a little frightened or unsure whether they should convey more information. If you did not understand something that they said or what they conveyed, you clarify as you go along. Don't wait for the interview to get over, because by the time you may forget this part. Also try to understand what they understand. What is their insight? What is their understanding about what is happening? You can ask them by asking like questions like, what did the doctors there tell you? What did the reports tell you? What was the discussion you had over there? Right? So these kind of questions, and many a times you will be surprised that many a times the patient's understanding of what is happening to them is very, very poor. Also ask them what their concerns are, what their priorities are, what their constraints are, financial constraints or logistical constraints. There can be many, many things. It is not just concerns about anxiety or fear of something. Of course, those things are part and parcel of what you have to ask about, but also financial constraints and logistical constraints. Once you have information, then share it honestly in a simple language without jargon. For example, you and I can understand the USG showed a cyst in the ovary. Nothing, it seems to be okay, benign. But if you tell like this to a patient, you can have a lot of problems, because when you say USG, the patient says, oh, the test done was wrong. I paid money for scan of my tummy, and they're talking about some other test called USG. There itself communication problem happened. And then they say there's a what you call cyst in the ovary, and it's benign, it's not a problem. So cyst in the ovary means that is cancer, and they're saying it's not a problem. There is absolutely something hanky-panky going on here, right? So when you use jargon, the patient and family sitting in front of you may be shaking their head, but when they come out of your room, they will have no idea of what they just heard. And this is why many a times people we know in our circle, they will call us up. Can you talk to the doctor? We did not understand. Can you talk? And that kind of things. So just this example that USG showed a cyst in the ovary, which seems to be benign. So a simple language will be your tummy scan report has come. It shows there is some swelling in the liver, which seems to be a normal kind of swelling. It does not seem to be a problematic swelling. Simple language, message conveyed. And the problem is that when we explain it with all this medical jargon, we are wasting our own time. And time is a precious resource, and we don't have time to waste. So good communication skill should save us time, energy, and effort. That is the whole idea of learning good communication skills. And it is very important to share information honestly. That also includes communicating bad news, but that we are not going to do today. We are going to do the next session. And once we have shared this information, not all sharing of information needs communicating bad news. It may be not such a terrible situation. But once you have done that, then we have to talk about what can be done about it. What are the treatment options? And there, if you are a medical professional, don't behave like a waiter in a hotel. You give a menu of option and you tell them you choose. You as a medical professional, you have to be a friend, a guide, and a philosopher to the patient and family. You have to give them the option you would take if it was somebody very close to you. And you have to think in terms of why you're making that decision. But remember, your situation, your financial, your logistical, social situation would be different from the patient. But at least you can give them a recommendation, not just a menu of options. you discuss about the pros and cons of, the possible options. And remember, the patient and family will have legitimate fears and anxieties related to the options. You have to understand that part. They may have legitimate constraints of finances and logistical. There may not be somebody to come and stay with the patient in the hospital. There may not be somebody to bring the patient to the hospital. So these are logistical problems, and these are real. So basically, in the old days, the doctor said, this is the treatment, take it or leave it, my way or the highway. But in today's age, we talk about taking decision by consensus. We usually talk to our colleagues. They take their opinion, and we come to a medical consensus of what is the best option for this patient, especially for serious medical conditions. For example, we have tumor boards or medical boards, these kind of things, or ethical boards. So this kind of decision making is happening in our healthcare system. What is not happening is, once you have reached a medical consensus, we also need to build a consensus with the patient and family, because after all, they are the experts when it comes to their life and their resources and their constraints and their beliefs and their fears. So once you have a medical consensus on what is best for the patient, sit with the patient and family and discuss this, and then take a decision. And this will be called participatory decision. So this is a decision by consensus of the medical team, the patient and family, and everybody concerned. Now, it is not very difficult. It is not very time consuming. It is a skill that you practice enough, it becomes easy. It becomes second nature to you. It is par for the course. It does not take much effort. And there are many advantages to it, because what the decision we come to is the most practical decision that can be taken. It may not be the best option, but it will be the most practical option. And practical option is what actually gets done, not necessarily the best option. There may be some problems with taking the best option, but the practical option gets done. And what gets done benefits the patient, family, and you. So that is the advantage of participatory decision making. Another advantage of participatory decision making is we are all collectively responsible for what we are planning to do. Because the patient and family has been taken into consideration, therefore, they also understand what is at stake, what are the possible negative outcomes, everything. It's not just, we just tell them this, sign here. That kind of that is not participatory decision making. That is basically you behaving like a waiter in a hotel. Right? And once all of that thing is done, just a short summary of what happened in that decision. And then you tell them, okay, this is the plan, and this is come after 2 weeks or 1 week or 1 month, whatever is this thing. And in our home care program, we see that many times the family members may tell that the patient has so-and-so problem. And then I ask them, why don't you take the patient to the hospital, to the treating doctor? And they say, but the doctor told us to come back after 2 weeks. And still there are, 5 more days to go. But I tell them, but in case you have a problem, then why are you waiting for that thing? But they never told us that we could come early. Now, from our point of view, as healthcare professionals' point of view, it may seem like common sense. Why does somebody have to specifically tell us that in case there's a problem, you can come early? It seems like common sense, but please understand, it may not seem like that to the patient and family. Their doctor said, come after 2 weeks. We can only go after 2 weeks. I mean, how can we go early? Now, this is something that we hear very often. So when you are discharging a patient, or you are seeing a patient in the OP or home care, tell them the plan. Okay, the next plan is to visit after 1 week or 2 weeks or 1 month. But in case you have a problem, feel free to come early, or feel free to call us early. Tell them that option. And that is how you close the interview. And the last thing last thing is ask, is there anything else that you want to ask? Is there anything else that you want to say? So depending on the mood, I would say, is there anything else that you want to ask? Or in other situation, I will say, is there anything else that you want to say? And that is the sweet dessert at the end of a good meal. It brings a smile to the face of the patient and family, and they'll say, no, thank you, doctor. And with that is the smile with which they should be walking out of my OP, or you should be walking out of their room or their home. So you should, that is how you should close the interview, with a positivity, with a smile, irrespective of what is happening as far as the medical condition is concerned. And then in the end, greeting, just the way you start in the beginning. In the end, there's a greeting. You make eye contact, you smile, nod, wave, or you say something that is culturally appropriate. So finishing off with today's session, a long session, take home message. All that we have learned today as part of active listening is the message of empathy. People hate when you show sympathy. Oh, poor person. No, this is sad. People hate that. So empathy is trying to feel what they are feeling. You can't obviously feel what they're feeling, but you can make an effort. And all these things that you have learned is the effort in trying to be empathetic. Because empathy as an experience depends on how we behave with our patients and their families. And no matter how many degrees you have, or no matter how many accreditations your hospital has, no matter how many crores of instruments and equipments your hospital have, patient and family may not remember any of that. They will remember how you made them feel. Most often, that is the only thing that people remember. So, good communication skills is not about talking more, it is about listening more. And not just listening, it's about active listening. Active listening is a very, very dynamic process. Everything that you learn today, as far as body language is concerned, the verbal do's and don'ts are concerned, it's all active listening. With that, I finish. In case you would want to contact me on any problem in your professional life as far as communication skills are concerned, that's my number. You can WhatsApp me on 9895604926, or you can take my number from Pallium India. I'll be happy to help you out. Many people do contact me once in a while. Don't call me, send me a message on WhatsApp, and I'll try my possible best to help you, mentor you, and so that you get better and better, and you end up teaching others communication skills. Because the more of us are better equipped with communication skills, we make our life, the healthcare professional lives, better and better. So with that, I conclude. Thank you. I stop here. I will stop sharing as well. There you go.
Thank you very, very much, Dr.
No, I think,
Biju Raghavan.
I think I wanted to say it was an excellent lecture. The way he conveyed with an example and how very understanding for us, the main thing is this communication skill is lacking everywhere. I think he has brought out very well. It has to be appreciated. I think we have to give a big applause for him. The lecture was so superb, I would say. Awesome.
Thank you. Thank you so much. Dr. Mahapati, thank you for your kind words. Really appreciate it.
That was really good, sir. Okay.
Thank you. Thank you so much. And compliments, it raises your spirit. It gives you energy. So my life's policy is at least compliment one person at least once a day. Somebody should be complimented at least once a day. It makes them happy. It generates happiness within you. So thank you so much. Your words really uplifted my spirits today. Thank you so much.
Thank you, sir.
Smile takes us a long while. So that is so important. That's a general standard statement. And you have brought that out. And why not? When it's available, why waste? Why do you miss on it? So that is something. So, and important thing is that as we started off, this is a skill. Even though being selfish, two people are benefited at the end of it. You are benefited and also the patient. So something which could be developed, practiced like our other skills, this is another skill. And it is very, very helpful. Both personally also it will help. So you're uplifting yourself in your walk of life also. So I'll just have a look at the chat box for any questions, or should we go with the case? Maybe we can go with everyone has appreciated and applauded you, sir. So if you could go ahead with the case presentation and then go to discuss.
Hello.
Yes, Dr. Subrita.
Can I begin?
Yes, please.
Okay. So yeah, this is my case presentation. I am Dr. Subrita James, and I am a junior medical officer at Jeevan Jyoti Christian Hospital, which belongs to EHA. So this is a case that I saw last year. She's a 52-year-old female, and her main diagnosis as such was metastatic osteosarcoma of the right knee. And we had at that time we had a surgeon who was taking care of medicine too. So we had she had already received chemo and radio and all of that. She was just there for palliative care, and she also had hypertension, type 2 diabetes, and she also had gotten a DVT of her right lower limb. So she was admitted around 8th of March in my ward, and she mainly came with complaints of back pain since 3 days. And she had this breathing difficulty since 3 days, and there was a slight decrease in oxygen saturation. And there were complaints of pain over her left-sided upper back of the chest. And this pain as such, when asked more, it increases when she inspires. And there's complaints of increased bowel and bladder movement, and complaints of pain and swelling in the lower limb. So then she actually is a diagnosed case of metastatic osteosarcoma of her right knee. It has been there since 3 years, already diagnosed from a tertiary care center. She was on palliative chemo and radiotherapy for 15 cycles, and now she was on chemo. So the last cycle as of was 4 months ago. So we saw her in March, but she had her last cycle in December, and she was on pasopamine. And she also had a history of hypertension and diabetes since 10 years. And also she had this DVT of her right lower limb, which she started experiencing after her diagnosis and after treatment. And it was there since 6 months. So we had put her on some anticoagulants for that also, as the trauma was going every day. So her vitals as such, when she first arrived, her saturation was 92%. So, and it was on 8 liters of oxygen. And her respiratory rate was around 35. Heart rate was on the higher side, and BP was 110/80. But, when she first came, she was a little bit agitated, I would say. Like not very, something was bothering her when we first saw her. And her otherwise, on examination, her CVS was fine, her CNS is also fine. On respiration, she had bilateral creps, and there was some sort of pain. As I said, she had pain on inspiration, so pleuritic chest pain, and mild tenderness over the left scapular region. Otherwise, she had some generalized tenderness all over her abdomen, and the lower limb, the right limb where she had DVT, it had edema also, and there was tenderness also. Oral cavity had an oral thrush. So there were a lot of investigations done on her, but we did do a routine investigation of CBC, electrolytes, PTINR, and D-dimer. So basically that was done for multiple reasons. First, to rule out any secondary infection if she has any. The CPC was done for that, and since she had complained of certain amount of bladder incontinence, we just wanted to rule out any dyselectrolemia. So we found out that the sodium was low, and then we gave her normal saline. PT-INR was done because she had already been diagnosed with DVT and she was on anticoagulants. So we just checked her PT-INR also, and it was elevated. And since it was elevated, then we got a D-dimer done, which took it took 1 day, but that was also elevated. So we had some suspicion of pulmonary embolism in her, but accordingly we just did. No, yeah, thank you. So she got a PET CT, which was done in December, and it was showing the same lytic lesion in her right lower femur, L3 vertebra, and T11 region, sclerotic lesion. So the left external iliac lymph node was also involved. So there's we could see that multiple soft tissue density in the left leg. Same findings consistent with an osteosarcoma. And it was metastatic also, so that's why we saw those lung lesions. So mainly here, since we're talking about communication skills, so as I did mention before, she was a little not herself. There's something going on in her mind. So she has been admitted multiple times before, and apparently when she was admitted before, she had this hope that she would get better, and she was getting better. So no one had actually given her explained to her the prognosis of the diagnosis. They just went along with the fact that she is happy about the fact that she was getting better. Even when she came to us at that time also, she didn't really know how deep the profound impact of the disease was in her life. So she mainly was more irritated. She knew that she had some sort of a cancer, but she thought that she would get better. So she used to express grief to us about her sons not being married, and she would even disturb other patients in the ward. And she was admitted in a ward where there were already 10 patients, and among these 10 patients, it was not like all of them were palliative or with significant diseases. Some were surgical patients, some were gynae and OBGY patients. So it was a mix of patients. We couldn't really keep her in a separate ward, which we should have. So then she had this personality also, as I was saying, that she kept accepting that her current condition was something that she'll get better from, and she'll go and she'll sort out all the issues at her home. And for her, her main worry was all the issues back at home. And it was difficult for us to even tell her that, her current condition is something that she has to be extremely worried about and not about other things. And she would just ask for painkillers to relieve the pain. So she went through, bargaining and grief and denial. Even when we gave her painkillers as such, it did not relieve her pain completely, because she expected just to get better. And we were thinking what is exactly going on, because she wasn't getting better with heavy painkillers also. Then we realized that there's something emotional and physical aspect that's playing a huge role here. She was actually pretty depressed about the fact that she had been going to the hospital multiple times. She strongly believed that finally she would get cured. But then later on, slowly she developed lack of interest in talking, lack of interest in anything, lack of interest in eating or having an appetite. So we then realized that her pain as such is not only because of the localized, or the metastasis as such. It is actually emotional for her. But it took us a while to realize that, because we couldn't as such give her much time and talk to her. And if we had done that, I feel that she would have opened up even more. And even she did not know, or maybe we just couldn't get to her directly. So it could have been relieved by, music therapy or aromatherapy or some sort of spiritual help that could have been given for her. So medications as such, we did everything possible. So the usual protocol of airway, breathing, circulation was followed when she came in. And in view of the previously done PET scan, it showed features of metastasis. So she was admitted in the ward because of her relatives. We also explained to them about the prognosis and that it has already been metastasized. So she was connected on oxygen and her vitals were monitored. Her INR was high, so we gave her a vitamin K shot of 10 mg to prevent the bleed. And we repeated the coagulation profile in 2 days' time, and it was then back into the therapeutic INR range. So she also had some severe pain over her right scapular region. So that's why we got a D-dimer done, and we did further investigations also. We had to send her on for a CTPA, and she was also given a diclofenac patches, thinking that it would relieve her pain, but it did for a while. However, it couldn't be continued for a longer time because it didn't show any relief. So the thrombolysis was not considered as they had already opted for, they didn't want to do any further treatment, the family members as such, and they just wanted palliative care. So we got a consent sign and everything. So her sodium levels again was low. It was around 123, for which we treated her with normal saline, because it is, since she was not herself as such, and she didn't exactly have her, her intermittent drowsiness was not exactly due to the hyponatremia as such, we felt, my consultant friend. So yet we just corrected her hyponatremia. So then we found out she had oral thrush also, and then we gave her the local oral antifungals. And our consultant was regularly monitoring. We were in touch with him, and everything was being monitored so that we can adjust our medications accordingly. And aggressive treatment was not done. It was fortified as the patient's outcome was expected to have a poor prognosis. And our palliative team also, as such, it's just us and another doctor who visited the patient regularly and titrated the doses regularly for a holistic approach. So yeah, so one thing we realized is that since she didn't even know her the extent of her disease as such, no one had ever told her what exactly would be the end result of the disease. She just thought that she's going to get better. We could have gone about breaking the news to her in a better way, and instead of it's very hard when in a hospital setting like ours, wherein we have to take care of multiple patients at the same time. But still, if we are given a little more time, or probably used more people, then it would have done better. So a protocol which I have come across is the spikes protocol. So it's basically, S stands for setting the context, P is for perception of the patient, I is for invitation, K is for the knowledge that the patient knows, and E is for the emotional aspect of the patient. So setting the context as such. So in this, as I said, she was admitted in a ward of 10 patients. So throughout the history of the patient's illness, it was necessary that to avoid the lack of confidence from the patients on FCP. So the family members knew that, but she didn't really know much. And she was in continuous pains, and when she was on regular visits from other patients also would complain that she used to be very disturbing. Like she used to have moans and groans, and that would cause a lot of disturbance to the other patients around her. So we should have shifted her to a early comfortable setting, which we did, but it was later on of her admission. We should have also seen that, her privacy and her comfort would be the first thing in line, because that is how we can give her the best of best care. And understanding of the family's background was a must. She kept saying her sons had to get married. We never bothered, finding out more about it. We just knew that she wanted her children to get married, but we couldn't I would say it didn't ever click to us to ask about whatever was going on at home. So yeah, but we did ask after a long time, I would say, after a week or so, that we went and asked what exactly is happening. And a lot of things was happening at home for her. So we should have taken time initially only. We should have sat with the patient and the attenders at the same time, or maybe at two different times, and then spoken to the attenders and known what their concerns was, what their idea of their patient's disease was, what their expectation is out of us. And we have also sat with the patient too and known the same thing, the idea, concerns, and expectations from both of them. And then, so the patient's perception as such. So when we ask about her condition,
Excuse me, dear. Sorry to interrupt you.
Yeah, sure.
Just I wanted to mention that as Dr. Raghavan mentioned, no, we are going to deal with this in our next thing. This is what, so sorry, because I thought it might be better to get his opinion also, because we are going to deal with this entirely as breaking bad news in the next session of communication.
Okay.
So sorry for interrupting. Don't mistake me at all.
Oh, sure.
Okay.
Okay.
No. So I thought, so because this is what is going to be, just I would prefer to Dr. Biju Raghavan, what would be your opinion also? Please.
We are definitely going to cover this in the next session.
That's why
but
I
if you could just, because we are a little short of time also, but
exactly.
Dr. Suprita has put in a lot of effort to make these presentations.
I know.
So Suprita, just breeze through it. It will be a revision
exactly.
for all of
Thank
us.
You, sir.
Yeah.
Thank you. Suprita, exactly that's what I would prefer. Not to get offended at all, dear. I'm very, very clear. Okay, your efforts are always appreciated. And only thing is that because we need to have some discussion if someone has burning issue, and exactly this is what we're going to cover next. So if you could finish it up, please. Summarize.
Yeah. So basically what I wanted to say was, more than even breaking the bad news to her, a good communication with a dying person. So she died at the end, but it took a long time for us also to get to know her as a person and for her to express her wishes to us. And if we had done that from the right beginning by giving her enough time for her to talk to us, then maybe we could have improved her care even better than what we have done for her. We did do as much as we could, but it could have been even better, I feel. And so her expressed wishes should have been, actually considered, and that would have avoided certain misunderstandings between the family and the staff and unnecessary distress as such. So I think that should be like a focus that we need to have as with us as well as the nurses also. So that's basically good communication is a very important aspect, which if we are done before with a lot of patients, we are not able to do it as such in my hospital as per se. But if we had, spent more time with her, then even earlier we would have, helped her out with her problems in life. And as for the concerns, the next slide that I have, So how to initiate a communication with the patients and family when my main point of question was when we are in a low resource setting, or say in a secondary care or primary care hospital, wherein patients don't want to go to tertiary care for end of life care. We are also handling other kind of patients at the same time, and mostly it's just one or two doctors who are on call, and it's very hard when such a patient comes to give them time, and even without meaning sometimes we snub them. So how can it be done better, and how can not only doctors but nurses and the entire team as such help out in such a situation with the family also, because here we had to talk with the family to find out a lot of things. So I'm done.
See, by attending, thank you very much, Suprita. See, today's session was to develop that skill.
Yeah.
So with less resource and less time, you can be more successful. So if you develop the skill with the same amount of time, you will achieve more. So the skill development is the important thing, which will help you. Exactly as you said, doing something more for the patient is what is our aim. If we could have made her happy, or in the sense happy, in the sense made her convinced that what her situation was, and that would have given her so much of better feeling. Exactly what we learned today. So making her feel better would have been much, much more better than the treatment per se also.
Yes, that's what
We'll ask Dr. Biju's opinion also, please.
Actually, I'll be very interested to hear from our other participants for today's program. If
Yes.
I might put in my two words at the end,
Yes,
but
yes.
I'll be very interested to hear from our other members.
Please either
Yes, sir.
unmute yourself and speak, or just type on the chat, or do whatever you feel comfortable, please. The rest of the...
Hello, sir and ma'am, and Dr. Tribeni here. And can you hear me, ma'am? Can you hear me, sir?
Yes, ma'am. You're on.
We can hear.
Okay. So, all this session, like when the first class, we like the pain, when the concept is there's a total pain, and it's not about the treatment part. As a whole, we have to see what the patient is going on. So today also it was an important part. We're looking into the total, the point of the case discussion about this patient. If if it was not only a patient who's having cancer or some physical issues that patient is having, if we see the patient as a general, that what other factors or the patient is dealing with the emotional state of that patient, or in fact any patient come to us, so that I think that is what about the whole part, that the communication or the to understand the patient, not only the physical part but the emotional, the total pain, psychological, at home, or what are the financial things, what are resources are there, who are family members, how they are coping with this news. So many factors add to the pain or the distress of the patient more than the disease itself. So I think, yes, we should have a multi-pronged approach for especially palliative care, or when a patient we know having cancer and we don't know how much time the patient have.
Communication skills, that's what. Starting right from the beginning, entering inside, then coming out, exiting, and what all happens in between should be make the patient very happy or understand what we say, and we understand and we make
Yes,
them
sir.
understand. That is, and
Yes, sir.
that I think the doctor has very well presented. It's I can repeatedly say and appreciate him, and he deserves it. Okay, the way he has put in.
Thank you, sir.
I would firstly want to thank Dr. Biju and also Dr. Suprita for wonderful presentation. I think I just want to add one comment here about communication skills, and that is this quote by Mark Twain. It's kindness is a language, which even a deaf can hear and even a blind can see. So this is something I think we all should keep in mind as doctors, because I understand in a country like India, where the doctor patient ratio is not proportionate, where we have so many patients to attend to, and we understand that we don't have enough time to give to our patients, even though if we want to, because of the number of patients we see. I think in every field, whether it's palliative or medicine or surgery, it's very important that like Dr. Biju said, a human touch is very important. Small gestures of kindness matters the most. A smile, a touch, opening the door for the patient, taking the names correctly. So I think these are some small things that we all must keep in mind. And of course, no matter how many degrees we have, it's important that we don't treat our patients like they don't know anything. I'm the doctor and you are a patient. And, it's important, like Dr. Biju mentioned, that, it's important to bring them to treat them like equals, not to demean them, not to undermine them. So these are some communication skills that we all should practice. And especially as junior doctors, we have the time to actually spend with patients, maybe after class or after, during rounds or after rounds, when we can go check on our patients if the patient is doing well or something like that. So these are some things that communication skill, and especially when communication skills are not taught to us in medical school, it's something that comes to us when we are in practice, when we are in our wards, when we are seeing patients, bedside clinical skills. These are some things that we should keep in mind. It's not just about gaining knowledge, but also to maintain the humanity and continue, working as a team. So thank you very much for this lovely session. And thank you so much, Dr. Suprita, also for your efforts. It was a beautiful session. Thank you.
If any further comments? I'm glad that even though there were some time constraints, I requested some participation from other members in this group, because you heard really very good responses, and it's really important to hear, and that's what just happened. So every person who contributed on the chat or spoke here has been really enhancing our knowledge. And as Dr. Akshita mentioned about kindness, practicing medicine with kindness goes a long way. It does not take any of our professional skills. It just enhances it. Madam, with your permission, if maybe just a few concluding words from my side.
Yes, please go ahead.
Regarding what Dr. Akshita said, our country till now didn't have a communication skills training program for medical professionals, doctors, nurses, but the Atmos program, which has come up recently, is making an effort into it. So at least the new generations will have some exposure. And for all the young doctors, having some kind of training in communication skills like what we're having today will serve your selfish interest. If you want to crack USMLE and PLAB, many of the times brilliant students from India, they get stuck at the communication areas. And also when you go to developed countries, I know for a fact that many of the Indian young medical professionals, especially doctors, face a lot of problems because they are not trained in communication skills. And somewhere our educational system and our gurus needs to bear a little bit of blame for that. For one, as a policy, we did not have communication skills as part of a training program. It was not tested. Our clinical skills were tested, but our communication skills were never taught or tested. And many a times the role modeling has been deficient, inadequate, and sometimes outright wrong. And that is why we, in the changed environment that we are here, we are practicing the old kind of practicing communication skills or whatever that goes it. And we are into a lot of trouble with a lot of lashback from society. So if the society does not trust us, maybe we are not trustworthy, or at least we don't seem to be trustworthy. And that is why learning communication skills is for our own selfish interest, because people who in the good old days, there were islands of good communicators. but the rest of the medical community survived because the our patient population didn't have much choice, and neither were they empowered enough to have a backlash at us. But now things are changing. There is democratization of information, and with that, because earlier only very few people had knowledge and rest had to depend on us. Now there is democratization of knowledge. Many people who have a certain kind of disease, they are much more well informed about that particular medical condition than most doctors, except the doctors who specialize in that medical condition may have more information, but they will have more information than rest of the other specialists or rest of the general practitioners. So there is a definite democratization of information, and as a result, we have to learn to be a little bit more humble. We have to approach our patients with kindness, empathy, and humility, knowing that they also know a few things, and many times more than sometimes what we do about our own areas of expertise. With that in mind, good communication skills that we learn, please understand, is for our own selfish interest. It should save us time, it should save us energy, effort, and plus it should enhance our professional lives. Better people with better communication skills will have more patience, and hence they will have more money, and their family will have better house, better car, their children will have better education, they will live in much more hopefully comfortable and secure lives. Money does not buy everything, but it buys a little bit of comfort and security, some amount of comfort and security. But again, the point is, we must learn communication skills as doctors and nurses. We must learn communication skills for our own selfish interest, and it's no surprise it helps the patient and family and society in general. One just a small example of how I save my time, energy, and effort. When we are dealing with very sick patients or very severely ill patients, we usually have the system of two family members come and talk to us, doctor, what is the problem? And then we sit for half an hour, explain everything to them. And the next day, two new family members comes and says, well, doctor, what is the problem? And then we explain for another 15-20 minutes. And then the third day, new set of family members come, doctor, what is the problem? And then now you are frustrated. And then you say, oh, what the hell, this is getting terrible, because you are spending so much time, energy, and effort, and just repeating this is not good. I definitely don't have time to waste like that. So whenever I am dealing with a patient who is very sick or having a lot of complications, problems, and a family needs to be counseled on it, I tell the family, see, there I have something important to talk to you. I need all of you who are stakeholders in your patient's care, those who are the decision makers. Let's all sit together and talk. During COVID times, I just moved it online. But pre-COVID, it was my room. I always have a couple of plastic chairs stacked up so that apart from the regular furniture, I always have more, places to make people sit. Easily in my room, 10-15 people have sat. As a matter of fact, the patient's immediate family members, close relatives, decision makers, even neighbors, sometimes because they are all, because the family depends on the knowledge and connections of the neighbors. So basically the point is, as a doctor, I am comfortable dealing with a large group of patients sitting in front of me. I am not afraid of talking to a crowd because I am the master of my environment, right? And I'm confident of dealing with it. The confidence comes, one, with the knowledge, the medical knowledge I have, and plus the communication skills that I have. So basically, I have one sitting with everybody concerned. And as a result, what I say is heard by these 10-15 people at the same time. Because everybody is there, and nobody's left out. There is not one kochachan or chacha waiting outside who is feeling humiliated and now his ego is poked, and then he or she will next time will put a spoke in every decision that we come to a consensus with its family and create more and more problems within the family dynamics as well as our ability to take this matter forward. So when everybody gets a chance to be there together, nobody's ego is poked, everybody is given respect, everybody is included, and as a result, everybody is on the same page as far as information is concerned. And if somebody has a question or a suggestion or a concern, anything that comes up in the meeting, everybody hears it at the same time. Many times, I just had to sit quiet when somebody asks a question. Another family member will answer because that person knows it more, or I will answer. Basically, I kind of orchestrate. I am the orchestra master. I orchestrate a counseling session discussion, and at the end of it, I'll spend the same time which I would have spent with 2%, maybe half an hour. But now I'm spending it 10, 15 people. We have had a good discussion. We have discussed all the concerns. We have asked all the questions. Everybody who had any doubts, that is taken care of. We have arrived at a decision by consensus. Time saved, energy saved, effort saved. It works in my favor. Right? So that is just one example of how communication skills can help you. So this whole concept of only 2 people should come into the doctor's room, I decide on that part, not the little girl who stand outside who says, oh, no, only 2 people can go inside the doctor's room. No, as a doctor, I decide how many people comes into my room. Right? So please be the master of your environment. You manipulate it to your advantage. So that was just an example. With that, I'll stop here. And if any other questions and queries, I'll hand the baton back to
There is just
Radha
one
madam.
message in the chat box. Can you just be quick and ask your question, doctor, please?
Yes, please.
Yes, ma'am. Yes, sir. So when the discussion was going on, like sir was telling me that now patients know better than some doctors unless they're specialized. So it looks like we can compare now the patients who are coming. They are like, they know everything about Google. Any symptoms we tell, they will check immediately over phone and they will have the answer. So it's like our children also nowadays, like parents, they know less because they know more of technology. They are more into good technology driven anything, because we have to say, oh, we have to ask someone, but they have already all the answers. So I think we have to not overpower them, but we have to know, like, very careful what we are giving the information, and we have to be 100% correct. We cannot tell that I am in the control and I know everything, because they might be knowing more than that. If they don't know also, immediately they'll come to know within 5 or 10 minutes, because it's such fast nowadays. So I think I just want to give the message. Thank you.
Couple of points that came out of it. One, from our point of view, remember in our college days, I mean, we in our MBBS days, we are young medical students, and we are in a, we have our classes, and the teacher just points out at one person, you stand up, what is the question, what's the answer to that question? And if you don't know, then that is the biggest disaster in your life. You wish you were Sita Maya and you just go into the earth, and because that seems like a better option than facing your friends, facing your everybody saying, oh, you don't know the answer to that. And the person who says that they themselves may not know the answer, but not knowing an answer seems like such a big failure. But the point is, we just possibly can't know the answer to everything in this world. I don't know the origin and insertion of Palmaris longus. Do you? I'll be very surprised if you do. Is that something to be ashamed about? No. If we don't know something, just acknowledge, oh, I don't know that, and probably I look it up for you. That is what I'm talking about, humility, that knowing that even though I am the professional, you paid the fees to come and see me, you know something more than I seem to know. Okay, that's fine. Don't grudge people the ability to know more, especially nowadays. It doesn't take effort, right? So it doesn't take effort. So okay, something like, I really don't know. I mean, where did you get that information? Okay, right, fine. Yeah, thanks for that. So that should be the approach. And if it is something that you think is wrong, but you're not very sure, I said, hey, I think maybe you need to check up on the source of it. I think it is not that. I myself am not an expert in this field, but I know there is my colleague in that department who's an expert in this field. If you want, I can refer you to him, and that person may be able to guide you better on this matter, right? So I mean, should I arrange something?
Attitude and approach might help, sir, in that, isn't it? Exactly, that's what you said. It's developing at. So basically, as sir has said, no, this is something we can develop, learn, practice, and perfect. So we can get there. It's nothing impossible. That is what to take home, I would say, from today. It's don't get scared. Everyone can develop. So let us all develop, learn, practice again and again, and be perfect.
Okay, will be. Thank you.
Absolutely.
Thank you
the
once again,
nicest
sir.
way to round it up, madam.
That's it. So thank you very much. It's nobody needs to be apprehensive at all. Everyone can master. That's all. And at least we have got an eye-opening session today that this is something which all of us would have had at the back of the mind, but it can be succeeded. And thank you very much once again, sir. Shripriya, you could take over then.
Thank you, Dr. Biju Raghavan. It has been a long time since we met, and you came back with a bang. Thank you so much, and we do look forward for the second part of your wonderful session in the future date. I believe this entire quorum will be coming on that day too. So with that positive note, there's a lot of appreciation for the faculty. This is Shripriya along with Dr. Biju Raghavan and Dr. Radha Venkatesan signing off from the Tips Eco Hub. Stay tuned for another interesting session in the next day. Till then, everyone take care. Bye-bye.